title of today's talk is General Considerations in Brain Tumors. This is the title that was chosen by us as a group, and I think it's actually a very interesting topic when I looked at it, because there's obviously a lot that you can do with it. And so I have a certain take on it that I hope is useful to you. And one thing I would say, obviously the topic is a very general topic, and so bear with me as we go through it. In our future oncology talks, neuro-oncology talks, we will address more of surgical aspects of brain tumors and surgical approaches and other angles that come into play in the field. But this one, being that it's the first one in this category, happens to be a more general one. So the objectives that I wanted to have in this, the objectives are first and foremost to sort of explore the decision-making process in the surgical treatment of brain tumors. And let me just explain that a little bit before we go on. In residency, I think that there's quite a bit of emphasis in patient care, but that patient care for residents really starts when the patient comes into the hospital. And quite often, if it's an elective case, it's done post-operatively, or intraoperatively, I should say, and then post-operatively. If it's a traumatic case, or trauma cases, or some other, few other types of cases, it can also start preoperatively. But usually, it's confined to that immediate perioperative time period. So that's really the emphasis, and you spend a good number of years really perfecting your skills as a surgeon in the operating room. But what's interesting is that there's actually a whole host of issues and thoughts that go into the care of these patients before all this, before you see the patient in the operating room, before you see the patient after the surgery. And I think that in most residencies there's a bit of a lack of concentration on that, or at least there's not a lot of development. So keep in mind that when you're done with your residency, really what becomes obvious is that there's really a whole host of issues that go above and beyond just the perioperative care that you experience. After we do that, we also want to talk about, consider some of the current controversies in management of low-grade and high-grade gliomas, and also maybe some of the pitfalls and pearls in surgical management of high-grade and low-grade gliomas. And future lectures will address other tumor types like meningiomas, mets, and things like that. So, in that regard, before I get to number one, let me cover a little bit about low-grade gliomas. So in order for your decision-making process that really begins the minute you see the patient in your clinic, as a referral or as a new patient or anything of that sort, really the first process that starts is you need to have information. You need to have a fund of knowledge that you can rely on so that the decisions you're making are actually making sense. So in this regard, let's just review some of the latest data that we have with low-grade gliomas and then high-grade gliomas. As you know, low-grade gliomas, the overall management of these tumors is really one of the most controversial topics in neuro-oncology, certainly for neurosurgeons as well as oncologists. So as you know, about 15% of all adult tumors are, to me, it's a little bit blurry. About 15% of all adult brain tumors turn out to be low-grade gliomas, and they include obviously a whole host of pathologies, astros, oligos, and mixed oligoastrocytomas. There's a biphasic nature to this, usually in the pediatric population between the ages of 6 and 12, and then later on between the ages of 30 and 50. Slightly different than high-grade gliomas. And the median age happens to be 35, which a lot of us are approaching or have passed. So it really brings it home. But the majority of these cases actually do present with seizures, and I'll get into that in a minute. And it's interesting that actually up to a third of these lesions can actually enhance on scanning. So the question that I will pose to you is that, this is something that's actually a known fact, in that when you get an MRI or you're looking at an MRI in the office, and you're in the back of your mind, you're trying to plan, the plan of care for this patient. What's the plan of care? Where am I going to go? How am I going to proceed? You have to keep in mind that what you're looking at on the T1 sequences with contrast often underestimates the actual extent of the mass. And the actual extent of the mass really is seen on T2 images. But the caveat here, of course, is that, let me ask you this. T2 can show true extent, but often is impossible to distinguish tumor from edema. True or false? Right. So that's actually a pitfall, because really quite often you cannot distinguish what's edema from what's tumor on T2 images. So really you're left at a bit of a dilemma at times when extensive resection comes into play. Now, with regards to survival, this is just some general facts that you may know, and it's just to refresh your memory. With regards to overall survival, median survival is about close to 8 years. Surprising, because a lot of people might guess that number is actually different. And 10-year survival rate is roughly about 50%. Again, these are rough numbers because there's a lot of different papers and a lot of different data that comes into play. Now, there's obviously significant clinical heterogeneity in these tumors. And this is really matched only by the therapeutic heterogeneity that you see. In other words, people can present in a variety of ways. Tumors can be in a variety of locations. Characteristics on MRI can be very different. But also keep in mind that depending on what part of the country you are, what country you're in to begin with, who you're seeing, who you're dealing with, who's the oncologist, who's the neurosurgeon, there's a whole host of treatment modalities that you might be subjected to. Observation alone versus biopsy versus resection versus XRT immediately or delayed. Because of this, because of the heterogeneity of the lesion itself and the heterogeneity of the therapeutic measures that are taken, it's very difficult to actually compare outcomes, and have a lot of the research in this area is very, very challenging, because it is very difficult to compare, essentially, and to have good controls. And of course, that's what this is, which is there's really no good prospective clinical trials that would really guide our decision-making process in a good percentage of cases. So, I pose this question to you guys. Prognostic variables can reliably distinguish those who may benefit from early intervention versus those who you may choose to observe. True or false? Justin? In other words, are there prognostic variables that you can look at and say, okay, this patient number 1, I'm going to wait and watch. Patient number 2, I'm going to operate on tomorrow. Patient number 3, I'm going to.
I don't think there's great data, but there's things such as age and.
Yeah. So very controversial. This topic is very controversial, because the factors that everyone has looked at, it's been very difficult to prove that any of them really mean anything, because there's been so many different ways of managing these tumors. So, but there have been numerous potential candidates for these prognostic indicators. As you mentioned, age, and that's usually the cutoff is 40, where they think that you will do better if you're less than 40 years of age. Seizures at the time of diagnosis is actually a positive as a presenting symptom. Absence of other deficits at the time of presentation bears a potentially good prognostic indicator. And a Karnofsky score of 70 or more. This should be equal or greater than 70. And also some people think there is some papers and some data on the mental status scoring that might be a good prognostic indicator as well. But in general, there is consensus that if the diameter is greater than 6 centimeters, then that can be considered as a poor indicator, and also presence of enhancement. Now this is interesting because, for example, just to give you an idea, enhancement can signify, so a tumor that is biopsied, right, and is read as a low-grade, let's say, glioma, which also enhances on MR imaging, okay, there is a very good chance that you might be dealing with a sampling error, right? Yet that tumor is categorized as a low-grade glioma. Of course, the outcome in that case, if it is not a low-grade glioma and it's a high-grade glioma, is going to be exponentially worse. So does that mean that every time you see enhancements, that is a poor prognostic indicator? Intuitively, that makes sense. Yes, most likely. But again, everything in this area you might have to take with a grain of salt. Histology also, MIB1 label indexes that are less than 8, and also oligos that happen to have chromosomal deletions 1, the 19q might be good prognostic indicators too. Now, let's look at some of the real data that's out there. And there is, in neuro-oncology, a number of papers that sort of everyone should be more or less aware of and have it in your memory bank. And I saw a paper by Dr. Jain in Journal of Neurosurgery of the top 100 cited papers in neurosurgery. Have you seen that?
Yeah.
That's a great list to also have and sort of look at and sort of make sure you've read most of it or at least know about most of those papers. But so look that up if you haven't. But one of the papers is this paper that was published in 2002, Pignati, which was this is the analyzed data that they took from the European Organization for Research and Treatment of Cancer. And there was a large trial followed later on by another one. And these folks took the data from this trial and looked at multivariate analysis. And they found really 5 prognostic factors related to poor outcome. Age, as we discussed, pathology of astrocytoma, diameter greater than 6, tumors that cross midline, and if there's a neurologic deficit pre-op. And based on this, they on this first trial, they developed a scoring system, and they put patients in, rated them from 1 to 3. And then depending on the number of factors that they had. So the low risk group, they had 1 or 2, and the high grade had 3 or more factors of the ones that we mentioned. And then they checked this data with the data that they had from the other trial, and it actually matched. And so if one is to look at a scan when you're with a patient and you're trying to decipher somewhat, where you stand in this category of low-grade gliomas as far as prognostication, then these are really the factors that you want to look at: age, pathology, diameter, crossing midline, and neurologic deficit at the time of presentation. Let's look at just a few cases together as we go along that presented to our emergency room. You might have seen, you might remember this scan about maybe 6 months ago or so, who came in with new onset of seizures, and on MR imaging had essentially this, and let me just tell you that there was no contrast enhancement. The patient was seizure controlled, and then was seen and evaluated by us. And I just want to know what your thoughts are about how you would proceed, what would be your next step for this patient.
This patient seems to have a couple of things going for him. Appears to be, as you mentioned, low grade, a younger patient presenting with seizures. So I think a resection would be indicated for him.
And I'm sorry, so the way I purposely, I'm leaving out things in the history so that we change our management based on what. So this patient actually also is left-handed. And the slide that I'm not showing you shows that this lesion actually extends inferiorly and laterally. So what's your next step?
Probably biopsy.
Biopsy. Okay, so a lot of people would advocate just basically resection of this. However, I mean, you would get like a functional scan and all of that, right? So we did a functional scan. His language actually maps to the left side. But, and that is what we did here actually in this case, biopsy. But another option would have been just resection, as much as you can. It looks like it's crossing midline here actually too, right? But you would essentially do a lobectomy on the right side. And another option would be to do a sort of a biopsy based on the frozen, then do the resection at the same setting. Now, in this case, for example, this patient actually, was in shock. He's a bodybuilder. He was lifting weights. He has a seizure. Next thing you know, he's in the hospital. He gets this, and now you're telling him, literally a day later, you come in and you say, okay, we're going to take you to the operating room. We're going to take out, a third of your brain, what it seems like to be, right? And so I will tell you that quite often patients aren't ready for that. They just are not ready for that. They can't accept that. And again, keep in mind, this is a controversial area because some people, this patient is now asymptomatic, right? So a lot of people might say, well, wait a minute, what's the, why are you doing that? So in this case, I decided to just do a biopsy because more than anything else, I wanted to buy him some time so that he could come into grips with what's at hand and sort of, move forward with surgery on his own accord, if you will. And that's what happened. We did the biopsy, and it was a low grade, and he went home. He actually saw other consultations in town, and at the end of the day, he is coming back to us next week for a session. So, which I think is a very reasonable approach. But the idea being that every case has its own little nuances and might be a little bit different. I'll get to that towards the end. So, one question that's always important with regards to our surgical approach is if the degree of surgical resection or the amount of residual tumor that you have has been found to be a significant predictor of outcome. Cheyenne, what do you think? So, intuitively, yes, there is some data that says yes, but there's also quite a bit of data that says no. And I'll show you that in a minute. And patients with clinical and imaging that's consistent with low grade can be safely followed with regular imaging without obtaining a definitive diagnosis even at the time of presentation. Without even doing, let's say this guy, without doing a diagnosis, without doing a biopsy, just waiting and watching him if he's asymptomatic. Yes, true, false? Cheyenne, Rahman, Dr. Rahman.
I think, I'd say yes. I'd say for some lesions, not for all of them.
Right. Again, controversial. There are people, I want you to know that. Now, our way at UCLA is not that. And again, every practitioner can advocate his or her own approach. But I can tell you that, if you were to argue that standard of care is such and such versus such and such, you cannot say that, from a legal standpoint or medical standpoint. Now, I can tell you that I think most of us in this room would be very uncomfortable with this approach, but it is done quite a bit in the community, and you'll see it in practice also when you go out there. So, very controversial because there's data on both sides of the spectrum. So the risk-benefit analysis when it comes to this wait-and-see approach is that if you have lesions that are surgically of higher risk, right, in eloquent cortex or close to it, you can avoid iatrogenic morbidity, mortality. You can avoid any deficits that may come after surgery. On the other hand, you risk progression. You risk progression to a point where the tumor now is not resectable, whereas it could have been, you could have had growth over resection before, but now you can't. You risk the fact that the patient might then come down with new deficits that you can't really reverse. And of course, there's this whole idea of malignant differentiation or de-differentiation. That's always there in the literature that people are worried about that, what if a low grade turns into a high grade? And also there's this whole issue of quality of life where quite a number of people without really having a diagnosis sitting around with knowing that there's an abnormality in the brain, they would be very uncomfortable with that idea. So that really puts a lot of psychological stress and affects quality of life. So one of the studies that was done quite some time ago in the early 90s, they did a small retrospective study to look at the consequences of the wait and watch therapy. They only had 26 patients in one arm and 20 in the other arm. But in this small study, they found that there was no difference in malignant transformation, there was no difference in survival, there was no difference in overall quality of life. But again, remember that the power of the study is very low, and the sample size is very low, and the study was a retrospective analysis, which is what it is. Now, I didn't want this to be there, but stereotactic biopsy provides accurate tissue diagnosis with minimal risk and is useful in directing the management of non-symptomatic tumors. Again, controversial because there are risks with a biopsy as well, and then there's this whole issue of diagnostic accuracy or sampling error, where you can really get a diagnosis for someone that's really not there. So now I ask you, Barney. A greater degree of surgical resection confers improved survival for low-grade gliomas. True or false? Or
was that the same question from before?
Or
was it the first question? Does
yeah. Well, again, I just want you guys to know that this is our practice here. This is what intuitively makes sense to us, but it is a very controversial topic internationally, nationally, in the community, and all of that. This idea of teamwork, working with the neuro-oncologists who are on the same frequency as you are, and neurologists and everyone else, becomes really important when you are in this scenario. So, with regards to surgery in low grades, only retrospective reviews are there and some case series, and there's really no class 1 evidence based on what we have right now. Just a few other studies that I think are important for you to know. Dr. Berger in 1994 did a study where they took 53 patients, and these were patients that had tumor masses greater than a volume of 10 centimeters cubed pre-op, and greater post-op residual mass. And they saw that those patients did much worse than patients who had gross total resection. Again, the power of this study was only 53, and it was a retrospective study. Claus in 2005, a more recent study, they took 156 patients. This study was really geared towards looking at the efficacy of intraoperative MRIs. But what they saw was that there was actually close to a 5% fold increase in risk of death for patients who had subtotal resection of low grades versus total resection of low grades. Johansson in 2003, they had a larger sample size, 993 patients. It was also a retrospective series. Again, they noticed that in this study, where the sample size was larger, they didn't see a statistical difference between the patients who had a biopsy, who had subtotal resection, or gross total resection. Now, the problem, some people say that there's a bias inherently in most of these studies, because the tumors that are not grossly resected oftentimes happen to be tumors that you cannot grossly resect because they are affecting eloquent cortex or other regions that you can't get to, and therefore those patients inherently will do worse. So some studies try to correct for that, but not all the studies that are out there. So this is the bias that would go towards the studies that would say that people with gross total resection do better than those who didn't have gross total resection. Now, radiation and chemo. I just had a lady in the clinic who was here for a second opinion, but essentially she was telling me that one doctor had told her her son had a low-grade glioma that was resected partially, and it's really not resectable. and then she was saying that one person told her that he should only have chemo post-op, and another person here at UCLA said, no, he should have radiation post-op, and she's like, why is there such a big difference? And again, because there is, again, some data, but there's really no reliable, consistent data that you can go with. I can tell you that quite a number of our cases here, like thalamic lesions or things that are not totally resectable, will get radiated. But quite a large number of them will, irradiation is delayed radiation, so that once there's a sign of progression, then we can have radiation. With regards to chemo, there's really a lot of work that needs to be done. So radiotherapy being withheld is controversial after surgery, and so is chemotherapy. There's really no good data. This is a case that I talked about briefly one time with some of you guys. You might know her, and so this is a 36-year-old female who presented essentially with monophoresis of the left lower extremity, which progressed over time. And she was seen by several neurologists. She had a muscle biopsy done. She was on IVIG for a variety of diagnoses. And eventually an MRI was done, which was indicative of this lesion. And at the time of this MRI, she was also pregnant, about 22 weeks. And so she comes to see you in clinic, and I'm just wondering what options you might present her with. Patrick, you know this case. Aaron, you don't know this case. So what do you think? And let me just tell you that because of her pregnancy, there was no contrast given in this study.
Well, the options for her are, I mean, probably the most important thing is figuring out what it is, I guess. You know, does she have any symptoms from it or no?
Yeah, dense monophoresis of the left leg. She's now wheelchair bound.
Yeah, I mean, it's sitting right in the motor cortex, basically.
Mm-hmm.
I mean, this could definitely be a meningioma.
A meningioma?
Not necessarily.
Okay, let's say it's intraaxial, because I had the luxury of looking at all the other images.
All right, I mean, you can offer her surgery. You know, she's probably going to be continue to be weak on that left side. You can do a biopsy. You can watch it until after she gives birth.
Okay, so
one question would be, what's the course of progression of her weakness? Was she walking before she was pregnant?
So over the past 6 months, she's become wheelchair bound. Which is a very good question, because if you're thinking this is a low-grade lesion, you know, what's going on? I mean, it's obviously progressing clinically to a point where she has dense monophoresis. So what you're doing is a risk-benefit analysis, like with every option that you gave her. That's the point that I want to really come back to towards the end, which is, so what do we do? Because the issue is complicated. First of all, you can't get a what I should have said is that we don't have a contrast image because she wasn't given gadolinium because of her pregnancy. So you don't know if this is a high grade or a low grade. I mean, at least based on imaging. You don't know if it enhances or not. Right? So that complicates the issue. The pregnancy complicates the issue. Her progression clinically complicates the issue. Right? And now the patient also comes and tells you that I need to know what this is. You know, this is, but at the same time, I don't want to lose the child because, you know, I'm 36 and I don't know if I'm going to have another pregnancy. And, you know,
was there an MR spec done?
MR spec was done and it was inconclusive as it always is.
I mean, I would lean towards resecting it. That's what that would be my. That's what I would try to advise her to do. Would be to. You know, to do surgery. She's 22 weeks pregnant.
Yeah, I would tell you that ideally to resect, like I would want to do I would want to get a functional MRI. I would want to get if I could, I would want to get a contrast enhanced MRI. I would want to get DTIs, and then I would potentially consider doing her awake, right? So all of this, in the context of a pregnancy at hand. It's not impossible, but it's just a concern.
The problem is that, it's just 22 weeks, right? So another 2 months or something.
Right.
What if this thing is causing significant mass effect?
Right.
And she's really having problems, and then you
Right.
have to do
I
something.
mean, also the
Yeah.
rapid
At
progression
that
of
point, she's
symptoms, you have to
36.
think this likely isn't low grade. It may be high grade.
Right,
because
exactly.
Or
Yeah.
she was
If
low
it's
grade.
high grade, and 22 weeks is like 5 more months of pregnancy, right? Or 4 more months
It
of
would grow
pregnancy.
very fast.
So she would die from that if it's
Right.
high grade. So I think you need an answer.
Right. This is exactly a great point because every case, the point I'm trying to make is that every case has its own nuances, and it's not a scenario when you are out in practice. It's not a situation where a given image you just put the variables into a computer and the answer comes do this or do that. It's every case is very, very different, and it's your approach should be custom tailored, custom made to the specific patient. So in this case, what I thought was justified was a biopsy, and a biopsy because we don't have contrast enhancement. I thought a needle biopsy might have sampling error, given the fact that, as Cheyenne said, there's clinical progression. So I decided to do a wedge biopsy, and we decided to do it just through a burr hole. Of course, the other option would have been dissection as well. Go in the next 7 minutes. I want to touch on some controversies and pitfalls with high grades, and then I want to talk about something a little bit different, which is just the overall approach that you might want to have. So with high grades, of course, this is high grade gliomas. There's a whole number of pathologies that are embedded within that. You guys all know that. I won't go through that, but again, this was supposed to be one of those flashy things we're going to do. So, but severity of clinical presentation can correlate with degree of histological malignancy. That's not true, right? It's the location that's important, right? And seizure activity can distinguish between a high malignant or a low malignant lesion. Again, that's not true, right? Because you can have a low-grade glioma that presents with seizures and a high grade that doesn't do anything until it's patient's comatose. Now, this is interesting. So, true or false that among all malignant gliomas, oligos have the highest propensity for hemorrhage, highest propensity to hemorrhage? True or false? False. So actually, that's true. But then also, if I ask you the second question, which is most primary brain tumors presenting with hemorrhage are oligos?
False.
Why?
Of course, that's not a likelihood of it being also.
Well, the incidence of
Incidence.
is much
So
higher.
the highest incidence is the GBM, right? And GBMs also have a propensity to bleed, although not as much as oligos. So therefore, that makes this statement false. Does that make sense? Sorry, I was thinking to go back to the iPhone. There's an app for that, by the way. Sorry. All right. So with the high grades, yeah, and this is a pitfall in that if you see a butterfly, obviously don't assume that. So let's say you're at the county hospital, you see an older gentleman, right? And by older, again, guys, this issue becomes sort of hazy, right? Not every 70-year-old is the same, right? You have a 70-year-old that's traveling the world and going on the Amazon tour, and then you have a 70-year-old with dementia that's wheelchair bound. So really, you got to consider that. And then when we get to age groups that are a little bit borderline, right? 65, 68, 72, 74. So you got to consider that. But so you are at the county hospital, let's say, you see a gentleman, an older gentleman, I won't specify the age, with a butterfly lesion, and I've seen this. I've seen people say, okay, this is the GBM, that's it. And you might be right the majority of the time, but absolutely not every single time, because you can have lymphomas, and as you know, and you can't even have oligos that cross through the corpus callosum. And as you know, both of those will respond a lot better than GBMs to a variety of treatments. So not to biopsy that or resect it or do something to it, I think, again, I can't say it's absolutely wrong, but, it could be questioned.
But is the prognosis any better
Okay,
Yeah,
for
primary
lymphoma,
central nervous system lymphoma is almost as bad as
well, but there is treatment for it, and you know, not to give someone that option, I think is a little bit problematic. What if it's an oligo? I mean, it's very, very low likely, but it can be. I'm sorry, Eric?
I just said that that's not true. Prognosis for primary CNS lymphoma is better. It's about years.
like a year.
No, it's more than that. It's more than that.
But you would agree that it is a completely different beast with a completely different host of treatment options and whatnot. So, but CNS lymphoma, especially if multiple and something that's crossing someone with risk factors for HIV, really should be considered. Just remember that some of the low-grade gliomas can enhance as well, and anaplastic astros and GBMs. Can sometimes lack enhancement. And I actually had a case that I didn't get a chance to put on here of a gentleman who was 76 years old, I'm sorry, who came in with a non-enhancing left temporal mass, okay, and which was incidentally found. And we presented the case in tumor conference, and we had a consensus that we decided not to do anything for the time being and watch it very closely. We did want the gentleman to have an MRI in 3 months and a PET scan, local PET scan. Unfortunately, he didn't show up for those studies, but he did show up 4 months later with a massively enhancing lesion at the same location. And then he had surgery. But I'm not sure if the outcome would have been any different, but nonetheless, it is something to think about. So that's, I would say, that is a pitfall. Now, this is interesting too, in that the incidence of distal recurrences and multifocal gliomas have become more frequent. Actually, some studies think up to 30%. And do you guys know why? It's not that GBMs are changing.
It's more diagnosis.
More diagnosis, and also because we've been so aggressive in treating them locally with surgery and radiation and chemo, that now there is actually some extension of life, and local disease-free intervals are getting longer and longer. So these things are actually, we're getting to stages where you can see them popping up in other locations. But despite all that, there was this one study in 1990 that compared the survival rates from 1935 all the way to 1980, and it noticed that the survival rates have really, the 5-year survival rates have really gone from 3% to 6% in this series. Of course, this 6% is a little bit different now, but still, despite all our efforts and all the technology that's out there, there is at least some papers will claim that we haven't really made much progress in the overall management of this field. Again, keep in mind that not every surgeon and every institution and every oncologist is as aggressive as we might be in treatment of these issues. But this study in 2005, the National Comprehensive Cancer Network Practice Guidelines in Oncology, they did a review of and they thought that the survival rate has increased from 11 months to 19 months, and they think that this is with resection, aggressive resection, and they think that reoperation can further give the patient another 9 to 12 months on top of that. Again, the data here becomes a little bit, hard to.
Purely survival without
Functional
functional
survival,
status.
right, exactly, just purely survival. And so here's another study in '95 where they looked at essentially age and histology, and they noticed that these are the numbers that, again, you don't need necessarily to discuss these numbers specifically with your patients, because again there is quite a bit of margin of error. But really, in the back of your mind, when you're seeing these patients, really this is what you're looking at. Age greater than 40 for someone with a grade 4, you're looking at something about 12 months. And that's with aggressive treatment.
That was from 2005, right?
Right.
Hasn't those numbers gone up?
Again, the
data?
Right, exactly. It depends on what number. They've gone up as far as 19%. You gotta got to look at what data, what set you're looking at. So there's a lot of variability. Now, so again, this statement is false in that if I were to say that there's definitive prospective randomized clinical trial data establishing that radical resection is superior to subtotal resection or biopsy followed by radiation, when it comes to survival, there isn't. Right? That it is our practice because we think that offers the patient the best chance, but there is no randomized prospective data on that. This one study in 1994 by Albert et al., they looked at the extent of resection and they saw that it surpassed both the age and the Karnofsky score as the most significant prognostic factor. They had a sampling size of 60 patients, and they saw that patients that had residual enhancement after surgery had greater than 6 times higher risk of death in that 5-year period. So, from a practical standpoint, we do surgery to get a diagnosis, improve the symptoms at hand, delay new onsets, increase the overall survival rate, and give a chance for other therapeutic agents like chemo and radiation to work, and also decrease the overall need for steroids. Theoretically, there is a number of theories that oxygen-poor tissue that is resistant to radiation therapy is removed while you do the surgery. Sequestered cells where there's necrosis and you don't really have much of a blood supply for chemotherapeutic agents to work are removed with surgery, and the overall tumor burden is decreased for other modalities to work better. So that's really a theoretical sense. But Mitch Berger in '94 presented class 3 data on 92 patients and showed that those with less than 25% resection had a median. This is really an interesting paper. Had a median survival of 32 versus 93 weeks. And 93 weeks was those who had complete resection, closer resection. So that's really one of the papers that everyone sort of hangs their hat on when they discuss surgical resection and aggressiveness with it. Another one with the American College of Surgeons showed that the 5-year survival for biopsy versus subtotal resection versus gross resection again went from 3 to 5 to 8. Again, not much of a huge difference, but statistically significant. And what I'm trying to show you guys here is the variability in the data that's there and has been there in the past 10 to 20 years. And that's exactly what makes the whole field very controversial. So this is interesting. Neurosurgeons' impression of extent of resection is usually accurate, right, Patrick? Of course. As much as I would love to say yes, it's actually false. And this very interesting study in 1996 by Albert showed that it was off by a factor of 3 on average. On average. I mean, we're talking about all neurosurgeons, that they looked at, right? So you think you got 80% of the tumor and you really got, 25% of it. So that's something to think about. Now, this is interesting too. I put this study, the Salmon study from '95, that post-op morbidity was considerably higher, significantly higher with patients who had partial resection versus with those who had total gross resection. And the reason for that is that I think you can tell in trials, if you're leaving tumor behind, there's a much greater risk for hemorrhage post-op, right? Because tumor tissue has a propensity to bleed. Much greater risk for edema, much greater risk for other immediate post-op complications in the hospital. And I don't know if I can really believe these numbers. I mean, it's 40% versus 3%. That's kind of a big jump. But certainly, if you have a patient that you're leaving quite a bit of tumor behind, I would be very concerned immediately post-op, because those patients are the ones who would bleed at 2 in the morning or have immense amounts of edema, angry tumor syndrome.
Did they consider why they were leaving that much tumor? Because maybe that's the reason. Maybe it was because it was extending into a brainstem or into more areas that were more violent.
They didn't leave 40%.
No, but
Why
it is
they
clear
left
why they left that tumor.
subtotal section?
Yes.
Yeah, that's a very good question. Although I submit
So it
to
is
you,
a factor of leaving tumor behind, or is a factor of a tumor being in a bad
right,
location?
which is the exact same issue that we touched upon in the low-grade glioma discussion, which is exactly right. The ones that that's why it's so difficult to believe this data. But I will submit to you that quite often in clinics, we see, and I'm sure you see this too, community patients who've had quote-unquote biopsies done in other hospitals or in community hospitals where you see that they have done a craniotomy flap, but a very small one for a GBM, and they have taken, maybe 5% or 10% of the tumor as a quote-unquote craniotomy for biopsy. They tell the patient biopsy, but really it's stated for billing purposes as sometimes it's craniotomy resection. Because once and in the old days, again, this was the standard of practice, where once the pathology, the frozen is a GBM, you essentially stop. There's very good data that shows that those patients, at least immediately post-op, do a lot worse than those who get a much more aggressive resection. This gentleman was only 27 years old. He had a prior resection. We knew his path was a GBM. He's had chemo and radiation, and now he comes back with this recurrence, and the oncologist sends him to your office. I think you have a number of choices. You can tell them that you don't think surgery is indicated. You can tell them based on the data that we looked at that reoperation can give this guy up to 9 to 12 months, depending on what data you believe in. Okay, he's only 27. Obviously, his prognosis is very poor. And then once you do decide to operate, then the question is what kind of an operation you're going to give him. He already has a flap on the left side. I didn't want to make him bifrontal either, so what we actually did, I think Asif was it? Yeah. So what we actually did was we went from the left side. We were limited with the incision that we already had, but we didn't do a bicoronal. We went from the left side, and once we got in here, all this tissue crossing the corpus callosum was really just all tumor. So we just marched over to the right side and tried to do what we could. So
I
that's.
think you made a comment before surgery, which I think
Yeah.
was really valid, which was that the tumor destroyed all that tissue.
Yeah, that's a very good point. And if you talk to Dr. Liao about this also, is that if you have, for example, like a low-grade lesion that's crossing, I would never chase it down the corpus callosum. People do get symptomatic post-op, and I don't think that's a wise move to make. In a case like this, like the aggressive GBM, I think all that tissue, as Asif saw, all of it was really, not functional tissue. And post-op did well. We did, you don't see it on this slide, but we did leave some residual, maybe about 4 or 5% on the right side. But the rest of it we just chased down from the left side.
Did you put bleeding in there or no?
No, the oncologist didn't.
It's over into the ventricle.
Okay, I want to take 5 minutes now, guys, and talk to you about something slightly different but very much related. Okay, and that is really about this decision-making process that you inevitably will have to experience and think about now, but you will really experience it when you're on your own after your training is over, which is you're sitting in your office and you see patient after patient after patient, and really you want to develop a sort of a protocol or a repertoire, if you will, with regards to handling each case or each patient. And all of us do this differently, okay? And so as long as what you pick is something that is that makes sense to you and that you can defend it when you discuss the case with your colleagues, as long as there's some line of logic. So what I would say is that when you are going through the decision-making process in your private practice, in your clinic, in your whatever practice you would be in, there are several considerations. First, there's the preoperative considerations, since the topic of this talk is general considerations and ranges. I would say first and foremost, consider the patient, right? Obviously, the patient's age, what symptoms they're coming through the door with, what comorbidities they have, also what wishes they have. The pregnant lady that we talked about, who was 36 years old, demanded to know what her tumor was. She wanted to know. There are other patients who would say, you know what, doctor, I really don't want to know. I don't even care if it's this and that. I would like to wait. It does matter what the patient says. You know, I think some of the older generation might dispute that, but I really think it does matter, especially in cases like this where quality of life is a big part of what's at hand. Logistics also matter. If you see a patient who is perhaps homeless, let's say you're in the county hospital, you see a homeless patient who you know is going to be lost to follow-up. This is not a patient who's going to get, you know, X, Y, and Z, or radiation, or follow-up with this and that. Then perhaps your management would be slightly different in that case. Okay, so logistics also matter. Or it's a patient who's an international patient who doesn't want to come back, or things like that. Just consider all of those factors. And then the other category is consider the tumor, right? So obviously what the location is, what the possible diagnosis is, and the rate of growth. But also consider the referring people who are presumably in your team, right? The oncologist who has referred you the patient, the neurologist who is on board, the primary care doctor. This is important not just in building your practice and your reputation and, you know, your standing in the community, but also it's important because if things change, if things go off course, or if things you know, become more challenging, you got to make sure that all of these people were really on board with you. So I would really advise that you discuss your logic with them, discuss your reasoning before you do the surgery. Have everyone on board with you. This is another case of a woman who is 87. She comes to you with left-sided facial pain. That's the only symptom she had. She's very fragile. She's 87. Otherwise, she's doing well and she's asymptomatic. When you said it, funny. But I think that, again, so imagine this lady is in your office, okay, and you're trying to formulate your thoughts, okay, and what I would say to a woman like this, and as I would say to the majority of our cases, I would say, look, we have three options, okay? We have the option of conservative management, right, and everything in life is a risk-benefit analysis, right? So the benefits of that is that there's no surgery, there's no invasion, there's no risk of anesthesia, there's no, you know, iatrogenic issues. But what's the problem? The problem is that there's a chance, there always is, that you might miss a malignant pathology, right? That there is a chance that her facial pain, her symptoms would get a lot worse, that her symptoms would get worse, right? And that there's a chance that maybe not now, but we don't know the rate of growth of this thing either, right? Because this is the only MRI you have this lady. Maybe, you know, 3 years from now, your hand is forced because this thing is massive by then. Maybe, right? And then what will you do? Because now you're dealing with a 90-year-old, right? So that's the downside of doing the wakeful watching or the conservative management. Now, radiation, is that an option? So radiation, first of all, you're radiating something without a diagnosis. That some people might have a problem with that. I will tell you that a lot of radiation oncologists do proceed with that nowadays, presuming that it's meningioma. But what's the downside? You don't have a diagnosis. Again, you might miss some malignant pathology, and also you don't. This is a pretty big lesion to radiate, right? So, and you're not sure that that's going to help her facial pain. Right? And so then the third option is surgery. And surgery either in the form of a biopsy or in the form of a debulking or, you know, whatnot. But again, what I would do is I would go through those options with the patient. I would go through that risk-benefit analysis with every option. And then at the end, I would say, now this is what I would recommend. These options are plausible options, but, you know, what I would recommend is that we do this and that. Given that you're 87, that this is what you look like, this is what this lesion looks like, and whatever. So I will tell you that, you know, I was worried because this tumor, if you saw the other scans, you know, it kind of looked a little bit fun. It didn't look like a true meningioma. I was suspecting schwannoma, but I wasn't really sure, and I was really worried that in this lady we would miss some kind of a malignant pathology. That was really in the back of my mind. Also, I thought the only thing that would really help her facial pain was debulking. But at the same time, I knew she was 87 and fragile, and I didn't think we should go to town, you know, the second we did it. So I offered her a sort of a minimally invasive attempt at debulking the majority of this with a sort of a small, sort of modified terional incision. Anyways, so this is what we did. You notice that we debulked the temporal fossa, but we did leave some tumor here. Coincidentally, the pathology came back as a type 2 meningioma, and it actually had a relatively high Ki 67 index. Who did I do this with? They're not actually they're not good at this. But the patient did very well. She went home after a few days. She did very well. And then the question, of course, was, okay, now, do we radiate or not, right? Grade 2, high KIC. So again, there was a debate. And again, there was this sort of topic of risk-benefit analysis came up. But I think that was the right decision for this lady. Her pain got substantially better. So she's off all her meds. So the only question now is to radiate or not. And I'll just tell you that our decision was to wait get another scan 3 months. Because in an 87-year-old, even radiation can substantially have them deteriorate. But certainly that's an option. So the question really, the first question is to operate or not to operate. Okay, and in order to answer that question, I would present all the data that you have, not in excruciating detail, but the data that you have, the facts that you know of, other resources, and even discuss the images in detail with the patients and the families. When people look at images, they actually can get a sense of what you're talking about. Orient them with the MRI or the CT. Tell them what's at hand, and they can actually get some kind of an understanding of what you're saying. And then present the patient with choices. Do not give orders to the patient. Give recommendations. You can say, look, this is what I recommend. These are our choices. Based on the data and the facts that I just told you about, this is what I would recommend. Based on that, this kind of else. But don't tell them, as maybe in some of the older generations, it would be like, okay, this is what you're going to have. And then they would walk away. Still, it's done quite frequently. I will tell you that, and also please understand that the patient will always have other options. You know what I mean? I can't tell you guys how important that is, and it manifests itself in every survey and every way that you can think of, from things like fundraising to things like surveys to things like actual patient care. It really matters. All right, 70-year-old. I'm almost done, guys. Just 2 more minutes. 70-year-old lady comes in. Her husband left her, and then she started having seeing spiders and having some hallucinogenic visual effects, which most likely you think are psych-related. But nonetheless, she ended up getting this MRI, and this is, believe me, this is as far as it gets. I would go through the options. I would do a risk-benefit analysis. I would say, look, the first option is not to do anything. Right? And I would go through that. Okay, the risk of that is that this is going to get bigger. It could be malignancy. It could be related to your breast cancer. It could be a glioma. It could be something else. Blah blah blah. The advantage of that is that you're not having surgery tomorrow, right? And we'll get another scan in 3 months to see what's going on. Now, keep in mind that if it is a malignancy and 3 months goes by, obviously time is not on our side. Second option, radiation. I don't know. Would someone radiate that without a diagnosis in the patient with a history of carcinoma? I wouldn't feel comfortable with that. I'm sure there's people in the community who would radiate that. So I would give that option to her, but I would give the pros and cons and say I wouldn't recommend that. Third option is surgery. And in the 70-year-old, the most minimally invasive thing I can think of here is an eyebrow incision, which puts you right above this, like a cure and taking some. So this kind of analysis, and let me just tell you that she chose to take this out really because of her history of carcinoma, because there was a worry about it. Yes.
How do you advise her regarding her symptoms? Because probably she wants to know if she's going to get better after.
I told her that I can never tell you. No one can ever tell you 100% that your symptoms are unrelated to this. But I will tell you that I think they are extremely unlikely that they are related to this. If there is some seizure activity that is caused by that, we can explore that, and that's certainly a possibility. But please do not go into this surgery thinking that we're going to take this out and your symptoms your hallucinogenic symptoms are going to go away. Anyway, so consider in choosing which operation the shifting paradigms. And as an example of that, I'll show you this very interesting case. This guy is 39, asymptomatic. He got a scan. This is what they saw. He came to UCLA. And for a lesion that doesn't really go laterally, it stays midline. And it actually, this number is blocking it, but it goes through the clivus. Part of it is, a small part of it is in the sinus. Right. And so they didn't even know there was a, my point is that when you, again, are sitting in that chair, even if you're not comfortable with a certain approach or certain, make sure you give the patient that option. And if they choose that option, then make sure you refer them to the right person for that option. It's extremely unfair to not even discuss that with the patient. And I think that if this is a great case for an endoscopic approach, where you can definitely get tissue diagnosis. You can go through the clivus. You can get a very good resection here. Sure, there's the concern with CSF leak and all of that, but on any day of the week, I think that beats a transfacial approach. This is another case. Okay, guys, this guy comes in. He says that he's 38 years old, and when he was 14 years old, he was shunted at another institution in Los Angeles. And now, he hasn't had any problems, but for the past year and a half, he's noticed really, really terrible headaches, memory problems, increasing difficulties with his gait. And so he had this image done. He goes back to the same institution, and the surgeon tells him that he needs to revise the shunt.
Okay.
Now, keep in mind, the guy is 38 years old. Well, I think this is a case where, again, the surgeon made the recommendation, okay, based on his comfort zone, okay, because he thought, okay, a shunt revision takes me, 20 minutes to do, solves the problem, whatever. But listen, the guy is 38 years old. How many shunt revisions is he going to end up having for the rest of his life, right? If he was 70 years old, then maybe you would say, you know what, yeah, sure, let's revise the shunt, low risk, all we need to do is keep this shunt working for the next, 10 to 15 years, whatnot. Even then you might debate it a little bit, I'll tell you that. But the guy's 38, so you would really think that, now, of course, you give him that option, but then you do the risk-benefit analysis, you tell him, look, why don't we get rid of this thing so you don't need the shunt? And so that's his post-op, and he will. So bottom line, guys, is this really, I just want to emphasize this because if you do this with the patient, not just in your own head, you go through this as a sort of a routine, as a repertoire that you develop with every patient, I think really it makes a lot of things go very smoothly. The patients like you because they understand what's happening, they connect with you, they are really appreciative, they offer that. No one has ever explained my problem to me. Thank you so much for doing this. And quite often, despite all the other factors or whatever concerns, whatever, they will be very happy to be with you. So I think that's would be my take-home message with at least